I'd like to introduce, and our next title is Clinical Trials in Black Men's Brain Health in the Greater New Orleans area. And so we're going to have Dr. Tom Leviste is the Dean of the Tulane School of Public Health and Tropical Medicine and Principal Investigator for Partners for Advancing Health Equity. His career has been dedicated to understanding the causes of inequality in health and its potential solutions. He has an extensive record of publications in scientific journals, as well as numerous mass media outlets, and is the director and executive producer of The Skin You're In, a documentary series about racial inequality in health. So now I'm going to turn it over, and I think you're in for a great treat. Thank you, Dr. Leviste.
Hello, is this working? Can you hear me? Okay. It's always interesting, right? When you say, can you hear me in the back? And then people say yes, but if you couldn't hear me, you wouldn't know to say that you can't hear me. So it's always interesting. Okay, can you bring up the slides, please? So good morning, everyone. Good morning. Good morning. Some energy, yeah. Waiting for them to bring up the slides. I want to talk to you this morning about the issue of trust. And I've titled my remarks this morning, Three Encounters with Trust. And this is 3 encounters that I've had with trust throughout my career and how I came to be doing research on trust, which was never my goal, never my interest. But at the time, I was in Baltimore at the time. I was at Johns Hopkins and took a sabbatical to work at one of the few remaining black hospitals. Back in the 20th century, there were black hospitals all over the country. The one in Baltimore was called Provident Hospital, which had changed its name to Liberty Medical Center, and I took a sabbatical and spent a year and a half working at Liberty, doing a number of things for them around the area of research. And one of helping them to set up their research infrastructure so that they can participate in research. And with a more than 95% black patient census at Liberty Medical Center, this obviously had huge implications for the black community in Baltimore, especially in West Baltimore. They asked me if I would do an evaluation of this new device that had just come out. This device was called the Health Buddy. This is back in the 90s. And this device was to help patients with congestive heart failure to manage their disease. And they wanted to know, could our patients with low literacy rates, could our patients be trained to use this device effectively? And they asked if I would help do the study to figure that out. And as part of that study, I did a series of focus groups where I had interviews with these patients. And the issue of trust was not part of the focus group questions. I hadn't thought to even discuss that question with them. But in every single focus group, trust came up organically from the patients, and it was every single conversation, every single focus group, every single patient, trust. And so I realized this is an important topic. This is something that we need to understand more about. So I went back to say, okay, what are we been doing, and what have we been doing in research on trust, and find out that really there wasn't that much research happening on trust in the health sciences, and the few little research that was done was based on a measure called the Trust in Physician Scale, which was asking patients about their trust of their individual physician, right? Now, if you have any choice in who your physician is, and you don't trust the physician, obviously you're gonna leave that physician, right? So getting information about the specific person missed the mark of most of the conversation that I had with these patients, which wasn't about a particular doctor, but do I trust healthcare in general? Do I trust this hospital? Do I trust these people? Not just the physician. And that's why I decided, okay, I need to do more. I need to create more of an infrastructure, a measure of medical mistrust. The basic narrative in our field, in the health sciences, is that African Americans don't participate in research, and they don't participate in research because of trust, and they don't trust the research because of Tuskegee. So here's the narrative. Everything was going along just fine. And then this one bad thing happened. And now that it's over, black folk just can't get over it. So that's the topic that I want to address today, that narrative. And why that narrative, if any of you hold that narrative, I'm hoping that I'm going to be able to convince you that that narrative is not accurate. And if we continue to operate under that narrative, we'll continue to miss the mark and we won't make progress. So, we used to always hear about how African Americans don't want to participate in research, right? In my experience, that was never the case. My training was at the University of Michigan. I worked at a program there called the Program for Research on Black Americans. And this was the first national survey of African Americans was conducted by this group. And that was the environment that I was trained in. After I left there, I went to Johns Hopkins and I conducted a number of studies. Never had I had African Americans unwilling to participate in my studies. So my question was, well, maybe because I'm black. Maybe that's why they're trusting me because I'm black. In many cases, the participants in the study had no idea that I was black because they never saw me. So they never knew that I was black. They just knew that they were asked to do the study. One of my former classmates, Raynard Kingdon, was at the time the director of the National Center for Health Statistics, and he commissioned his staff to do a study of all of the data sets that had been collected by National Center for Health Statistics in its entire history, and look at the patient refusal rates for studies. And what this study showed was that there is no race difference in willingness to participate in research, that is a myth, that is inaccurate. What there is a race difference in willingness to participate in clinical trials. That is different, that is a subset of research. But why clinical trials? Why? Because trust is much more complex than just, do I personally trust this other person? Trust happens on many different levels. We must trust the competence of the healthcare worker. We must trust that this person has been adequately trained, this person knows what they're doing, and this person is going to do the right thing, not necessarily because they care about me or not, but because they're a professional and their training is such that they know what they're doing, right? We have to also trust that this person has the agency. They have the ability, the power to do what they know is right. So even though their bosses may say, don't do that, or don't do this, save money here, that this person will still do what is right for the patient. We have to trust that. We have to trust that the healthcare provider has control, that the provider has the control to make the decisions. Trust is complex, and trust comes from many different places, and this complexity, I think, is a part of what has made it difficult for us to figure out how do we get more African Americans to participate in clinical trials. So my first encounter with trust that I want to talk about was a study that I did called the Cardiac Access Study. And this was a study that was conducted in Baltimore. And what we wanted to know was, did whether or not the patient received the proper care have an impact on the trust of the patient, right? So what we did is we abstracted about 10,000 medical records from 3 hospitals in Baltimore, and this was about a cardiovascular disease, and I won't get into that part of the study. What we wanted to know was, do these patients, if they receive the proper treatment, is it more likely that they will trust? And I'm going to skip ahead to this. So we asked a series of questions, first about satisfaction, about how satisfied. So we recorded from the medical record who actually got the procedure that they were supposed to get, and who had a good medical outcome from their procedure. We then went to those patients, we asked them a series of questions about their satisfaction with the care and about the trust that they have as a result of this. And these are some of the questions that we asked. What we found is that there were differences in patient satisfaction, right? White patients, on average, were more likely to be satisfied with the care they received than black patients. And this is because, in part, because white patients, on average, receive better quality care, which is not a new surprise to anyone in this room, I'm sure. We asked a series of questions about trust, and we found, again, that African Americans were more likely to say that they did not have trust, right? So this was also consistent with the narrative about African Americans and trust. And then we said, okay, what if you, I'm gonna skip in here. what if you actually receive the proper care? What we find, and here I've highlighted in red, that for satisfaction, African Americans and whites, there was no race difference, right? So African Americans were just as likely to say they were satisfied with the care if they received proper care than whites. But we found that for African Americans, the distrust still remained, even if they received the proper care. I'm going to skip ahead to the next encounter with trust. And this one was with a study that I conducted also in Baltimore on this question of Tuskegee. This narrative that Tuskegee is the singular reason for it, or even, and I would argue, not even a significant reason, it's one of the reasons, but not even one of the major reasons African Americans don't trust. We did a study to determine if that is really the case. This was a telephone survey we conducted in Baltimore where we asked, telephone survey was about 400 white and African American people in Baltimore, where we asked them a series of questions about Tuskegee. One of the questions we asked was, have you ever heard of Tuskegee, the Tuskegee syphilis study? And then if they said they hadn't heard of the study, we read a short description of what happened that had been written by CDC, and we said, this is what happened in the study, and then we asked them one additional question, which was, do you think this could happen again today? Right? If you said that you had heard of Tuskegee, we then asked you a series of questions about what you know about Tuskegee to see if knowledge of Tuskegee is really influencing this issue of trust. All right, so first we asked them, have you heard of Tuskegee? We see there was no race difference in whether or not they even knew about Tuskegee. Only 41% of African Americans had even heard of the Tuskegee syphilis study. So the majority had not heard of it. The majority of white respondents to the survey also had not even heard of Tuskegee. So the extent to which Tuskegee is impacting people is diminished when more than half of the people hadn't even heard of it. Then we asked those who said that they had heard about it, in what decade did the Tuskegee syphilis study begin? So let me ask you, in what decade? What's the correct answer? Is it 1890s? Did it start in 1930s? Who says yes? How many of y'all are afraid to answer? It's not a test. It's not a trick question. Did it start in the 1950s? Okay. Did it start in the 1970s? Okay. The correct answer is that it started in the 1930s. We then asked, in what decade did the study end? Did it end in the 1930s? No? 1950s? 70s? 80s? Okay, you got that one right. Those of you that were not afraid to answer. So, right. So again, here, no race difference. They were both groups, black and whites, were both inaccurate about this. We then asked, how many men were in the study? How big was this study? Was it approximately 75? Who says 75? Approximately 200? Approximately 600? 1,000? Of course, the right answer is approximately 600. Again, no race difference in knowledge about this. And of course, the vast majority were wrong. Then we asked who conducted the study, and I provocatively added Johns Hopkins to that list because I was worried about it at the time because I was there, but now I don't care anymore. But so who conducted this? Was it conducted by the U.S. Public Health Service? Okay, who says it was Tuskegee Institute? Well, that's, okay. Who says Johns Hopkins? U.S. Army. Okay. Okay, now the correct answer is U.S. Public Health Service. Although Tuskegee Institute did participate in it, so if you said Tuskegee, that could have not been an accurate answer. The U.S. Army was not involved in this one. I'm not saying that there aren't other things that they did, but they didn't do this one, nor did Johns Hopkins. And then we asked, but again, I want to stress here again, The vast majority of people got it wrong, but again, no race difference in the answers. We then asked, did the researchers give the men syphilis or did they already have it? And here are the results. Of course, the real answer is that the men already had syphilis, that they were not injected with syphilis. Here we do have a race difference in the correct answer, but this answer reflects the African Americans were more likely to be distrustful. They were more likely to believe that they had been given the syphilis. But here's the key question, and here's the bottom line question to all of this. Do you think this could happen again? So while we found that African American and white patients were no more or less likely to be aware of Tuskegee, they were more or less likely to be aware of what actually happened there, that there was this huge distrust that occurred that we're finding that is not specifically about Tuskegee. The majority of people didn't even know Tuskegee had ever happened, yet the distrust was there. My next encounter with distrust happened here in New Orleans. After moving here, I had the dubious honor of being the chair of the governor's COVID task force. So don't blame me. I wasn't the one that said that you have to stand in separate parts of the elevator or any of that, but I did help with some of that policy making. And the conversations that I had with people about trust was all about trust when it came to the vaccine in particular. I had people were telling me that this vaccine is turning people into zombies, that the vaccine was injecting people with devices that would allow Bill Gates to track them. I would ask people, why does Bill Gates want to track you? And if he did, why wouldn't he just track your cell phone? You're paying for the tracking device in your pocket that he can use much more easily. Well, why use this? But this, I'm sure many of you have had these kinds of conversations. I had a very serious conversation with someone who told me that the vaccine was turning people into zombies, and she was very serious about it. I'm convinced that she was serious about it. I asked her, had she seen any zombies? She hadn't seen any zombies. But there was a reason. There's a reason, because people are not irrational. There's a reason that people were willing to believe these outlandish things. There's a reason that people were willing to trust Pfizer for their Viagra, but not trust Pfizer for the COVID vaccine. Right? It's the same people. If Pfizer's evil, they're evil, right? So they're evil for everything. Why are they not evil when it comes to Viagra? But they're evil when it comes to right? This is what I was getting from these people. But some of that is our fault, to help sign us, the communicators. We were operating by the seat of our pants, no doubt about that. We were operating by the seat of our pants, and we were making up stuff because we were learning stuff in real time. But we made some really big mistakes. For example, can one of you tell me what social distance means? I thought social distance was the dumbest term that I'd ever heard until the next term I'm going to tell you about that's even dumber than social distance, right? So first of all, we're in a pandemic and we're telling people stay in the house. We're telling people don't go to the grocery store and buy all the toilet paper and water because other people need it too, right? So what we need is people to have social engagement, people to be thinking about the broader society. The words distance and social should never occur in the same sentence under these circumstances. But we create a term, social distance, which doesn't even describe what we were asking people to do. We were asking you to be physically distant. So why didn't we say physical distance and social cohesion, social togetherness? That's what we needed. That was dumb. That was an unforced error. But what was dumber was Operation Warp Speed. Okay, we're going to create a vaccine in months where past vaccines had taken decades. And we're going to tell people that we're going to do it with warp speed. Instead of calling this thing operation as fast as possible, but without cutting any corners and being really careful to do this so that nobody gets hurt, that doesn't fit on a bumper sticker, I get it. But that is the narrative, right, that we should have been putting out. Instead, we call it Operation Warp Speed. And I was in some of those meetings and asking people, why are we calling it this? What are we trying to do? And why is this meeting, why are the people involved only vaccine developers? A vaccine is not going to solve this pandemic. It will do nothing. The vaccination might do something if we can actually get a needle in arms, but you're not going to get needles in arms by only talking to virologists and vaccine makers. You need to be talking to sociologists and anthropologists and psychologists and communications experts and people who understand community, right? This was an unforced error. This was our error. We were the ones making these mistakes. We were the ones that were putting out these terms. And then we don't properly explain to people what a vaccine is and how it works. So people think, I get this shot, I can't get COVID. No, vaccines don't mean you can't still get infected. It just means that the virus will not have the same effect on you, right? And so instead of explaining that, when people started getting infected, even though they had been vaccinated, we created a new term, breakthrough infections. Well, breakthrough infections, right? Is that what we called it? Instead of just saying, no, that's okay, that's how vaccines work. You can get infected, but you're not gonna wind up having to go to the hospital and you're less likely to die because the vaccine works, right? So what we need to do in the health sciences is we need to take account of our own activities, our own behavior, and the own roles that we play in creating this mistrust. When we do these cultural competency trainings in hospitals and healthcare systems, right, who do we train? We train the healthcare providers. But who is the first staff person that you encounter when you drive up to the hospital? It's the parking attendant. It's the security guard. And if these people don't interact with patients in a trusting way, this can result in a bad interaction with that patient and distrust in the patient. So it all matters, everything matters, everyone matters in the organization. And this is where we come up short. So a couple of recommendations I want to end with. And a couple of lessons that come from my 3 encounters with trust. One is that we should always follow the voices of the study participants. You do a study in a community, you're talking to people, follow their voices. If I hadn't followed their voices, I would never have gone into doing this research on trust. But they told me, indirectly, they said, you need to do research on trust. You want to understand how to get to us? Trust is the issue. In their own way, that's what they told me. Next, trust is complex. It's very complicated. Trust is not just a simple matter of an individual trusting another individual. You have to trust an organization, you have to trust the process, you have to trust the people running that process, and you have to trust that the process is correct or accurate or is going to produce a good outcome from you. So we need to be sensitive to the fact that when people are sick, people are vulnerable. And when they are at their most vulnerable, trust is going to be important to them, and we must be trustworthy. There is no single cause of this trust. It is not the case that everything was going on just fine until Tuskegee happened, and now they just can't get over Tuskegee. What people know is about their cousin that went to the hospital last week and was mistreated by the security guard. They know about their neighbor who went to the hospital and didn't get the care that they deserved or should have gotten. They know about the person who was turned away in their own neighborhood, in their own life, their own personal experiences that stoke this distrust. It's not something historical. It's not something off that somebody else did somewhere else and we're the beneficial or the ones that are suffering from it. It is us. And finally, it is necessary that we learn to communicate clearly and transparently using language that people understand. And that will make us more trustworthy. And if we continue to operate the way we have, Operation Warp Speed, social distance, these sorts of things, changing, so the solution to when the monkeypox epidemic began to spread, and the first messages from CDC was, men who have sex with men, and I actually got so frustrated, I picked up the phone and called one of my alumnus who at the time was number 2 at CDC, And I said, what are you people doing? Why are you trying to tie monkeypox to men who have sex with men? It has nothing to do with who you have sex with. So we're once again miseducating the public. You can acquire Mpox simply by close skin-to-skin contact with someone who is infected, period. You need not have sex with them, and they need not be a male, and you need not be a male. So why would you message it this way and create this false impression that only men who have sex with men are at risk and everyone else is not at risk, right? These unforced errors that happen among us, the health researchers, the health scientists, the healthcare providers, and the fact that we're not properly trained to communicate effectively is a lot of which stokes this distrust, and that needs to change. Thank you very much.